Okay. So thank you everybody for joining us. I know most of you have attended our echo sessions before, so we're done with status, and we're going to start. This will be our first lecture on pediatric sepsis. So everybody knows the goal for these series are to provide education and really kind of create a community of providers and caregivers to share knowledge and experience. So everything is all educational and about collaboration and learning, no judgment. So as you guys know, we do record all of the sessions, and they will be made available to your team for people who weren't able to join us today. So by participating, you are consenting to being recorded. If you have any questions about that, please don't hesitate to contact me. And then here again is the CME information. It's going to be the same process for every single time, but if you haven't done it, here's the information. And if you ever have any issues or questions, just feel free to reach out to me, and I can try to help you as best I can, or get you someone that can. And then just remember, if you're claiming CME, it needs to be done by 11:59 today. And here's learner information from the CME department. Okay, so we'll go ahead and start with the didactic, and we're going to talk about, so very similar to how we structured the status sessions. Today we're going to really focus on recognition in the ED and kind of tools and talk about that. And then our next session we'll talk a lot more about treatment and where to go from there. So, right.
Okay. So y'all can see my credentials there on the screen in case you couldn't understand me before. So I've been here at Riley for about 6 years now. Come on, I actually know each other from our training. He was a fellow in the PICU at Cincinnati when I was a fellow in the pediatric emergency department there. So unfortunately, he's had to deal with me for a lot longer than I'm sure he would like. The other thing I'll apologize for is I'm wearing a suit, which is very out of the ordinary for an emergency medicine physician. Typically, I'd like to be in my scrubs, but I'm doing my administrative job today, so that's why I'm all dressed up. This is not going to be an uptight lecture, hopefully. It'll be laid back, but we'll get some good information out to you, and then hopefully you'll have a lot of questions. We can have a pretty robust discussion there towards the end. So, particularly today, I'm going to focus on sort of the initial aspects of pediatric sepsis, and really that's the recognition thereof, because we, as you probably know, we struggle with that both as a emergency physician group as well as healthcare just in general. So we'll go ahead and move on to the next slide. And this is not news to anybody that's on this talk today, but sepsis is a huge problem. These are the United States stats that you can see there before you. So somewhere on the order of about 75,000 children will be diagnosed with sepsis every single year, and that's increasing as we go on. If you do that math, which math was never my favorite subject, but that comes out to about 200 per day, and that's increasing by about 8% every single year. Another important fact, I think, is that about 7,000 of those kids will die every year, and it was a bit eye-opening to me when I first started this work to realize that that really is more children than will die of pediatric cancer in America, because we've done such a great job with pediatric cancer care in developed countries, and we're still just, I would say, in the infancy, if you will, to make a bad pun, of our recognition and treatment of pediatric sepsis. If you expand that out to look around the world, it's somewhere on the order of about 7.5 million children will die from sepsis. And according to the World Health Organization, sepsis accounts for the top 4, numbers 1, 2, 3, and 4 of causes of death of children around the world. So hopefully that convinces you, if you weren't already convinced, that sepsis is a big deal. It's a big problem, especially in little patients. So just continuing on that vein, let's look at just here in, again, the United States. Of those about 75,000 kids that will be diagnosed with sepsis, about 34% of those children who survive sepsis, and we'll talk about what the mortality rate is, will go on to have some sort of long-term neurocognitive difficulties. And about half of those will have to be readmitted back to the hospital for complications directly attributable to their episode of sepsis. In this day and age, we can't do anything without thinking about the sort of the cost of the care that we provide in each condition, and sepsis is really gets us on the hook for about $4.8 billion of care every year. Now, if we do a better job at recognizing that and treating that early, certainly that's not going to eliminate all of that cost, but we can drastically reduce the overall cost burden to our healthcare system. And we know that's a big deal, especially as we increase our spending year over year as a country, almost to where we're getting to pretty difficult levels here with the amount of spending that we spend in terms of our GDP. So before I move on into the actual nitty-gritty of the talk and the actual recognition of sepsis, let's talk about a couple of other ancillary points. So sepsis, as I've said multiple times already, it really is a big deal. About anywhere between 20 and 30% of children who have sepsis will die, and that depends on which study you look at. The most recent one that I looked at said 25, so we'll call that the ballpark. Of those, 50% of the kids will die within the first 24 hours of contracting sepsis. And we all know that about 80% of children in the country aren't seen at a pediatric specialty center. And that number that I quoted a moment ago of about 49% of kids that will die within 24 hours, that's prior to making it to a pediatric intensive care unit. So although we have the luxury here of having a PICU, I know a lot of you do not, and a lot of our colleagues that work in the community setting don't have that luxury. So recognition becomes even more important so that we can start them down the treatment pathway soon. And I'll just share a little bit. I like to be transparent in these talks. So you're listening to someone right now who, as I said before, is the quality and safety director for a hospital as well as an emergency medicine physician. And I've been deeply involved in our sepsis work here for the last year since I took over this administrative position. And somebody who's in it in the day-to-day bit of his work on both the clinical administrative side still is not awesome at recognizing pediatric sepsis. So I'll share a case with you. There was an individual that came into our emergency department. This has been within the last year, who was an older child. I noted that the heart rate was pretty fast, and he didn't look well, as you would expect. So we were doing lots of different interventions for him. We were doing fluids, and we were doing antibiotics because we weren't sure exactly what was going on for him. And he had some comorbid medical conditions, one of which we'll talk about a little bit later, that puts him at higher risk for having sepsis. But it wasn't until I had put in the bed request and he was getting ready to move up to his inpatient stay that I had this epiphany and said, oh my goodness, this kid has sepsis. And he'd been in our emergency department for about an hour and a half to almost 2 hours at that point. Luckily, we had treated him appropriately, but we hadn't actually had that thought and shared with the team to have a shared mental model that this kid has sepsis, we should be going full bore on a sepsis pathway. So pediatric sepsis is tough. If you work in my world or in your world, because as I said, 80% of kids are going to present to a community emergency department, the things you're looking for are the things that a lot of kids come into the emergency department with. And that's fever of 100.4 or greater. They're going to be breathing fast. They're going to have tachycardia. And the one that is not always there, but certainly is there a good deal of the time, is a drop in urine output. So on my next slide, it says that this is about 90% of the kids that I see, especially during the winter. Now, is it really 90%? I don't know. I made that number up. But it's a large percentage of the children. So that's really the monumental task that is before us, is when these children present to our emergency department, we have to sift through who has sepsis, who has bronchiolitis with a fast heart rate, who has gastroenteritis, which is leading to dehydration and a fast heart rate and a drop in their urine output, and who needs to be treated aggressively with the pathway that we'll talk about a little bit later. So lest you lose heart, this is a positive talk, although there's been a lot of negative things that we have shared about our ability to recognize sepsis. Some of the people, or some of this work has already been done for us, and we'll talk about that next. So thankfully, there was a huge group of hospitals, all pediatrics, children's hospitals, that got together and formed what's called the Pediatric Septic Shock Collaborative. So this was a partnership between the American Academy of Pediatrics and the Children's Hospital Association, which has members from all around North America. And they recognized, this was back in 2013, actually is when it started, and then really got off the ground in 2014, 2015, and the recommendations came out in 2016. But they said, boy, we really have a big problem with our ability to figure out who has sepsis and then put them into a quick, efficient treatment pathway for that. So it started off with about 47 of those hospitals. It's beyond the scope of this talk, but I can share offline if you're interested why there was only 47, because the membership of the Children's Hospital Association is much larger than 47. And then that weaned down after some of the reporting requirements, et cetera, to about 25 hospitals that participated in this initiative and carried it to fruition when they published their findings. And like with any good quality improvement project, which this was, they set a SMART aim. They wanted to decrease pediatric sepsis mortality by 20% in all of those institutions that participated by the end of the study period. And I'm happy to say that they actually achieved that. And they published this in their findings in 2016, but they are still publishing materials from this collaborative, with the most recent paper that just came out in the last couple of months by Raina Paul. She was the lead author out of Chicago. So I'm going to talk a little bit about the pathway first, but I'm not going to dwell for a long period of time on that specifically, because that will be the focus of a future lecture that one of my colleagues, I believe it's Tyler, that's going to do. So later. But essentially, this is the task that's before us. We have to sift through, find the needle in the haystack of kids who have sepsis and not some other condition when they come to our emergency department. And then really, we have about an hour to get them all of the therapies that we need to initially and get them moved on to their initial or their secondary place of treatment, whether that be the pediatric inpatient floor, if they're not terrible, pediatric intensive care unit, if you have such facilities, or transfer them to another facility. Now, does that mean you need to transfer them out within an hour? Obviously not. That's almost impossible. If you can do that, please talk to us, because we need to adopt some of those principles in our emergency department to help move kids up to the floor within an hour. But essentially, the literature would bear this out, that it's very difficult to recognize these patients unless you have a well-delineated recognition tool in place in your emergency department. And then from there, many of you know the guidelines that we want to get fluids, antibiotics. If they're refractory to those treatments, we then start pressors, which can be done through a peripheral line, if need be, and then move them on to definitive therapy. And I think that's about all I'll say in terms of about the pathway and the treatment of that, because I don't want to steal Dr. Arnold's thunder. So I want to focus more on how do you recognize septic shock in children. It's not the same as adults in that one of the things that this Septic Shock Collaborative found was that about 50% of kids who have septic shock will have one of the high-risk conditions. I realize this is a bit small on the screen there, but we'll talk about all of these things in depth, because essentially if you have a kid who is tachycardic, is tachypnic, their blood pressure might be a bit soft, and they have one of these high-risk conditions, or if they don't, just if they have one of the high-risk conditions, I would encourage you to have a very high level of suspicion that this child could have sepsis. And like, as I said, we'll talk about all of those high-risk conditions a bit later in the presentation. So this is actually what we are adopting here at Riley. And yes, you heard that correct, adopting, meaning we are currently in the process of adopting this trigger tool. we are hoping to put this into our electronic medical record. We use Cerner here at our shop. One other children's hospital has been successful in doing so that uses Cerner, that's Boston Children's. So we're in close contact with them to put this in as an alert that would trigger when a child comes in, if they get a full set of vital signs, and that's key, a full set of vital signs. Even here at Riley, we struggle sometimes with getting the blood pressure, because if anybody's tried to get a blood pressure on a 10-month-old or a 2-year-old who doesn't want you to get a blood pressure on them, it can be pretty difficult. We liken it in the emergency department, because many of us have children ourselves, to putting sunscreen on a child, which if you've never tried to do that, it's kind of like wrestling a rabid crocodile. So it's sometimes very difficult to do that. But essentially, the way our process will work, and even if you do this on paper, I would encourage you to have a similar process. When the patient presents to our emergency department, we get that full set of vitals. We have a table that you can see there on the right of your screen that indicates abnormal vital signs for that patient based on their age. And I would encourage you to use something like this. This table was put out again by the Septic Shock Collaborative and was specific for shock. You might look at those numbers and you might say, well, man, I mean, they have to be incredibly tachycardic to trigger this tool, or incredibly tachypnic to trigger this tool. And that was by intention. This tool is meant to be very specific, not sensitive, because what we don't want to do is we don't want to alert all the time. As I said, 90% of the kids, again, making up that number, coming into my emergency department may be tachypnic and tachycardic and have a softer blood pressure potentially. I don't want to be alerting my entire team and slamming these kids with fluid and things if they don't really need it, if we're not sure that they have sepsis. So once those initial vital signs are obtained, the other two key components, which is not routinely done, I would say based on the literature throughout the country in triage, is that there is a skin assessment which needs to be done. What does that mean? That's tough, right? Because that means that you need to actually undress the child and put them in a gown in triage, which is difficult even for us here at Riley, just the way our physical plant is set up. But that really is key, because if you don't look at the entirety of the child with their skin, you're going to miss petechiae. You're going to miss pallor or poor perfusion that you might be able to see visually when you're doing that triage. The other thing is a component that we just codified. I shouldn't say we, they codified when they put this in. It's often done, especially by seasoned triage personnel, but it's that mental status check, and whether they've got an alteration of their mental status, because as you well know, mental status alterations are indicative of end organ failure in kids who have shock or sepsis. So again, that's an important component to have. So once we do that assessment, then that triggers either that, yes, we think that they, by the trigger tool, they trigger positive for sepsis, or no. And if they don't, then they kind of go on through their routine care. I would encourage you to adopt a similar pathway. But if they trigger positive, then that's when you need to kind of go full bore and attack, that's a bad metaphor, approach these children with aggressive fluid therapy as well as early antibiotics, etc. The big question that we always get is, well, does this take away my ability to use my clinical judgment? Of course not. All clinical guidelines are to be interpreted and used with clinical judgment as well. We can all think of a few instances where a patient might trigger positive for the sepsis screen, but they wouldn't in fact be septic. But again, if they're triggering positive on this because it is very sensitive, I would encourage you to think long and hard before you say, no, this child doesn't meet the criteria for sepsis and doesn't need that sort of treatment. Back on that last slide, we don't need to go back, but again, we have these things posted in our emergency department, so that vital sign table that you saw there, the list of high-risk conditions is posted there as well, and the findings at the bottom on the right side of that slide, which was what would qualify for mental status abnormality, as well as pulse and skin exam abnormalities as well. Because in the high-stakes environment of the emergency department, anytime you can cognitively unload some of those things, you want to do that. You want to make it easy for your personnel, because we're all thinking about 100 different things, especially when we're triaging, my goodness. So, and we've talked about that, this slide sort of ad nauseum. So here, this is the high-risk patient that I would encourage you to think about. I won't insult you by reading those. You guys are all quite smart individuals and can read all of those conditions, but I will tell you, when we looked at our data here at Riley, and we had similar numbers to national numbers in terms of morbidity and mortality from sepsis, when we identified our sepsis patients, almost, I shouldn't say that, the vast majority of patients had one of these high-risk criteria. So anytime a child walks in with one of these, please, please, please think sepsis in your top list if they are evidencing some of those vital sign abnormalities, mental status abnormalities. And sometimes it's tough, right? Specifically with the kids who come in with a severe cognitive delay or static encephalopathy, which is cerebral palsy. So those kids can't talk to you, as you well know. A lot of my patients can't talk to me anyway because they don't know how to talk yet. So we have to really rely on caregiver and the objective findings that we can have from our vital signs and this. So we can move on. So again, if you look at those vital sign criteria, this is meant to be specific, not sensitive. So there's going to be a lot of kids that may very well have sepsis, but this doesn't catch. And I say that because in quality improvement, we always want to look at a balancing measure, or what are the potential pitfalls of putting in a process like this. So what we don't want to have happen is that your staff becomes completely reliant on this tool to catch all of the septic children, and then you miss folks that you wouldn't otherwise miss just because of your gestalt and that sort of thing, because you become overly reliant on the tool. So again, still think sepsis if they don't trigger positive for this, but maybe they're a little bit earlier on in their course. Because we all know children, they will compensate for a long time and then fall off the cliff, especially when they have sepsis. Okay, so I think that was about 20 minutes there for you. So I don't want to bore you. The adult attention span is about 20 minutes. So I think we'll stop right there, and I'll open it up for discussion. Happy to answer any questions about this or other topics.
I have one comment before you guys ask. I just couldn't help myself not getting excited about this. I really like the way that you approach this topic, apart from just the traditional way of presenting sepsis recognition. I think what a lot of us don't know much about is what's out there number-wise, objective metrics of morbidity and mortality for our pediatric patients with sepsis that come to the emergency department. So that's really important highlight of, how do we do it in the ED, how do we do it in the PEDS ED, and how do we do it in the PICU? There's so much differences there. So I would like to hear actually from all of you guys, since we've been to all of your ED sites, what's the overarching theme or questions or issues you might have versus what you want to ask Dr. Wagers about the presentation. I'd like to have like an interactive discussion about this.
Yeah, this is John Schmitz from Hendricks. I think your talk was really good. One of the things that really resonated with me was when you were talking about alerts and kind of balancing the sensitivity and specificity for these sepsis criteria. We have several alerts already, and adding additional alerts into an already alert-driven system, trying to be able to recognize that that 1 out of 100, but also not overwhelm where you're alerting on every patient. I know that our hospital, we've used the SIRS criteria for adults, and as you guys know, you can get SIRS criteria just by working out in the yard, or when you get flu season or bronchiolitis season. It seems like everybody would be alerting. So one of my questions is, as you guys have been looking at this at Riley, what have been your experiences with that? Have you guys seen with the criteria that you've used, have there been over alerts, or what have some of the doctors that have been working, what are the experiences with the alerts that you guys have talked about?
That's a great question. And I'll give you two different hospitals' experience. So again, back to this, when they made this, were pretty sensitive to alert fatigue. So when they studied this at Boston Children's, they found that about 1 out of 50 kids would trigger this tool. So for them, they see about 300 kids a day in their emergency department, so that was giving them about 6 per day. For us, give or take, we see around 150 or so. So we're looking at about 3 of these alerts on average per day. Of course, that's not, no day is average in the emergency department. So there may be one day where you have 10 of these, and you might go 3 days without one. So we're looking at essentially about 1 out of 50 patients, which our docs felt like that was probably a good balance between alert fatigue but still catching enough of these kids for it to be a worthwhile endeavor. Hopefully that answers your question, John.
Yeah, cool. Thanks.
Yep.
I'm curious, does anybody currently have any sort of triage tool or anything specific to pediatric sepsis that they're currently using, or is anybody talking about using anything in their current practice? Is it just triage as usual?
This is Dawn from Community. We don't have anything specifically for pediatrics right now. Obviously, we do have a need for it. We're very focused. We were very focused on the adult population, and now we're just starting to look at the pediatrics. I did receive a screening out of Tampa, Florida, I believe. I have a colleague there who sent us their screening at their children's hospital.
Specific for sepsis, Dawn?
Yes.
So you're well spoken when you say that most folks have been focused highly on the adult population and haven't yet sort of waded into pediatrics. There was, as you all know, there was a recent law passed here in Indiana that requires us all to be looking at sepsis. So the Indianapolis Coalition for Patient Safety will be working on a pediatric sepsis recognition, treatment, all of that. That should be coming from them. That group will be starting later this summer, so you can look for that as well.
That hospital screening was St. Joe's in Florida.
Does anyone else have any questions about the presentation, or any other questions about sepsis or recognition? Are there any other resources or tools that anybody uses currently? I mean, it doesn't have to be a screening tool, but I know most of our resources are focused on treatment. Is there anything else anybody wants to share that they've been using or find helpful or not helpful?
Hi, this is Allison from Anderson. We don't necessarily have an official tool that we, like a screening tool that we implemented, but it's more of just something that we did to help us recognize it. It's more of an alert for the nurses to notify the physicians if there's certain parameters. So It's just like a double checker that we have to connect and click, do they exhibit any of these signs? And it's a list. And if so, we have to notify the physician, but that's just kind of a double checker for the nurses and to get the physicians involved quickly.
Okay. And that's in triage, Allison?
It's done a little bit of both. It just depends on if there's available beds or not. And if the vitals are done. We don't have a great triage process out front for vitals to be done. They're not always done out in triage because we don't have an area out there. So depending on what is done out there, yes. If not, it's done in the back when they're in a room.
Okay. Any other questions?
Hey, can you hear me? Okay, sorry. This is Lori. I'm from Community South, and I was kind of piggyback on what Allison said. We have worked on just our pediatric triage in general because we don't see a whole lot of peds and we don't have a PICU, and so most of ours end up leaving and going to North, so our nurses are not as comfortable, and a lot of times they come in and they just go straight back to a room. And we've worked really hard on our front triage of like getting vitals and trying to visually look at the kid to see if they are sick or not sick, and that's made a big difference. So like, I love this information because I feel like we can add this to education and it'll give them other things to like continue to think about. So no questions, just kind of that's my take from this.
Yeah, thanks for sharing.
And I think it's important that we don't have this figured out. Like, we're not 100%. We're like I said, we started this journey about a year ago, and we're in the implementation phase of all of these sorts of things that we're talking about. So we're right there with you guys. So we're moving forward together.
So I went ahead and put together a case study, but one of these days I'm going to get one of you guys to send me a case and have you present it. But just for sake of, I only included kind of the beginning part of this case, and since we're just really focusing on recognition, but this was a transport I did fairly recently to a hospital that was a very small community hospital that's quite far away from here. So this was a 4-month-old female who's 4.5 kilos, had a pretty extensive past medical history. She was born at 24 weeks, had a very long, complicated NICU stay. Of note, complicated, I think, most by necrotizing enterocolitis. So she had several abdominal surgeries, had an ileostomy that had since been reversed, but sounds like already had a pretty extensive history in the NICU. She had an abdominal wall hernia, chronic lung disease, and her baseline that she was discharged at home was a 1/4 liter nasal pee. So she had not been home for very long. Also had, she did not have a G-tube. So was basically brought in that morning because mom said she was just extra fussy and had some emesis. And so I think with her just extensive abdominal history, mom was appropriately concerned and brought her into the ED. So if this patient were to arrive into your ED triage, what would kind of your first steps be? And anyone can answer.
Across the room assessment.
What was
Hold
that?
on, you beat me.
Okay, I'll be quiet, Lori.
No, that's okay. She said across the room assessment
Okay.
to
And,
see if sick.
okay.
And what do they look like?
Okay.
Like when you saw them across the room, and then I would make a decision, my next step based on that.
Okay. And then how many people, I know Allison, you said that you guys don't have a great area to get vitals in triage. How does that work for everybody else? Does everybody get vitals in triage? I'm not an ED person, so I don't know how triage works.
So it just depends, like Allison said, if your ED's full. We do a pool to full. So if you come in at 6 a.m. and I got 1 million beds open, you go straight back to a bed and the primary nurse is called to your bedside. If it's 9 o'clock at night and your waiting room's full, then it depends on what that kid looks like, right? Or the adult. You come in and you look really bad, I'm finding a bed for you, right? And we're going to finish it up in the back. If you have an earache, you're 3 years old and playing and eating, the triage will be done out in the front. Other than that, you're coming back and being triage completed in the room.
Okay. Okay, so this kid comes in, your across the room assessment, which I love that phrase, is, I do, laugh at me. You can just, baby's lethargic, mom's holding her in her arms, but kind of appears lethargic and has very poor color, is mottled throughout, and pretty significantly distended abdomen. So if this is a busy time, say you don't have a ton of beds open, where would you guys kind of go from there? And this is more for my knowledge as well. So again, I don't know how all this works.
For Sal, she'd be going straight to our shock rooms.
Okay.
I mean, and it would probably be like a team activate so that we get the doctor as well as our primary and secondary nurses in there to start the care and assessment and kind of figure out what's going on.
Okay. Is that pretty standard for everyone else, or do you guys?
Same as Anderson.
Okay.
Yeah, same at Hendricks.
Okay. Okay.
Same at North.
Okay, let's go to the shock room. So you get back in the shock room, you've got your team there. What are some of the first things you guys want to know? Or what are the first things you're going to do?
ABCs.
Yes.
Do I have an airway? What's my breathing look like? What's my pulse look like?
Okay.
What's my color look like?
Perfect. So she's lethargic but responding to pain. So now remember, we have a pretty extensive history. She does have chronic lung disease. She's tachypnic with intercostal retraction. Sats are 87% on her baseline quarter-liter nasal cannula and having some intermittent apnea. And then perfusion, she's, again, model. She's very poor perfusion, delayed cap refill, heart rate is 180.
No heart history from the NICU? Like she didn't have congenital heart defects?
Nope. Great question, though. Is there another vital sign that we might want to get?
Temperature.
For sure. I don't remember. What else?
Weight.
Weight, yeah. Weight in kilograms.
Do you guys, what would be your typical process for that? Do you guys weigh your patients? It's like you have beds that
This patient would probably get a linked base tape to start with.
Is that what everybody else does? Like Roslo? Does anyone have beds that way, or do they?
Well, in our shock rooms, we do have beds that weigh, was 4-month-old? Is that what she was? I mean, we would probably do that, or, sorry, I share an office, so it's kind of loud. So if we couldn't get what we felt like was a accurate weight, we'd do the Broslo.
Okay. What do you guys do in Riley? Would you Broslo this kid, or try to get away? You get away.
We get away, because even some of our curves have weight. So what if she weren't febrile? What if her heart rate, or rather her temperature was like 35.6?
You're assuming we all do Celsius, so convert that for us to Fahrenheit, and then I'll tell you. So I don't have to figure.
I don't like to do math. So let's say, what if she were, okay, so she's 96.3.
Ooh, she's hypothermia. She can still below a normal temperature can still be sepsis. You can either be hyperthermic or hypothermia.
Right. And the other question you want to ask is, how did they take the temperature? Was it?
Ooh, talk to us about that, because we have big controversy here over this.
Okay. Go ahead and ask your question. I'd be happy to answer.
First of all, let me tell you, I'm a clinical nurse specialist, adult. So everything I find gold standard is still a rectal temperature, especially if you suspect an infection of an unknown origin. And everything else I find say that tympanic is really inaccurate, especially considering the environment, along with the temporal. Our for the most part, 1 axillary.
Yeah, so I will say that a lot of times we get axillary temperatures as well and have to ask for a rectal. I think what you said was correct. So the temporal and the tympanic. If you actually look at the literature, some of the literature actually says that they're fairly, you can compare them pretty well to a rectal, but I will tell you that the technique is so important when you do the temporal or the tympanic thermometer that's where I see the variation come in. So you're right. The answer is that you need a rectal temperature on this kid. So this was a big question of all of our emergency departments that we just standardized last year. They had the same question to us. And we standardized it up to 6 months. Everyone should get the temperature should be done rectally. And ideally up to a year, it should be a rectal temperature. And you're going to see some pushback on that. Because again, for us, our initial triage, unless it's pool to full, we do that at times as well. But in the busy times, our triage area is a little walled off, but it's also in the middle of the waiting room. Not the middle, but in the waiting room. But there is some walls, but so it's, sometimes parents don't want you to put a rectal thermometer, and take that temperature that way in the waiting room, essentially. But you're right, that is the right way to do it. The rectal temperature is the way to go.
Good questions. What's one more vital sign that we want?
Where's your blood pressure?
Blood pressure. I'm curious what everybody does, because this specific facility did not have a blood pressure cuff small enough to obtain a blood pressure on this child. She was 4.5 kilos, a 4-month-old. She's a little chunky 4-month-old, but so I'm just curious if you guys get blood pressures on kids, if you have policies, because I think this is another thing that I know we've talked with some of you about when we come to Sim Day. It seems like everybody kind of has a different policy or procedure. So I was just curious what you guys do. Or if you guys have policies on it, or if it's just like per your discretion or per physician order.
And Anderson, we do under 5, but if it's a sick kid, then, I mean, that's different. If they're there for, a hand injury and they're under 5, we don't necessarily do it, but any type of sick illness related, then we do it.
And how do you define sick? Is that based on like their ESI scoring or just?
Yeah, I mean, more like infection related, like not injury related, more if they're there because they have a cough or a fever or, I mean, yeah, it's more, I guess you would leave that discretionary.
Yeah.
We have a policy. I'm not sure it's followed.
Okay. What is the policy?
Yeah. But the blood pressures are taken on all patients 2 years of age and older, and for younger patients who are unstable or have suffered a head injury.
Okay. Similar things that they don't know, that's fine too.
I work with Dawn, so that's what we do. And again, sometimes the policy is followed and sometimes it's not.
Let me ask you this. Does everybody have, what's the smallest size blood pressure cuff you would carry? Do you have small enough equipment to, if you needed to get a blood pressure on a kid this size?
We do at North. We have infant cuff.
Or do you guys know?
We do as well.
Okay. Anyone else? Does Riley have a policy or is everybody get a blood pressure?
No, so we have a policy and ours is very similar. So we attempt to get a blood pressure on every child. Mm-hmm. But my least favorite thing is UTO, under the blood pressure.
Unable to obtain.
Unable to obtain. But our nurses are actually really good about getting blood pressures just because that's what they do.
So when I obtained a blood pressure, it was 44/16. So I don't know if you guys know, is that normal? Too high, too low?
Before anyone answers, I have a question. When you have such a blood pressure, I want to compare to what actually we do at Trinity sometimes. Do you believe this one? Do you say, oh, it's just the blood pressure is too tight or too loose? Or do you act on it? Do you repeat it again? Like, what would be your first, reaction after this? Because I get so many different actions. Sometimes I don't believe in myself because I don't want to. And I would like to reflect to that and hear from you guys. What do you do with this blood pressure?
This is Michelle from Hendricks. I would repeat it.
Ideally, I would do it manually.
Okay.
All right, and this is Michelle. I would do it manually as well as a repeat.
What else? So I don't have the ability, I don't have the equipment to do a manual blood pressure when I'm on transport. So that's not an option for me. I did repeat it in this case because I didn't want to believe that. But also, do we think that's true based on our total assessment on the patient? What would you guys say?
I would be afraid it is true.
Yeah. I mean, it made sense, but I didn't want to believe it. So we did repeat it. And we did, I worked with my partner and kind of said, hey, do you think I have the right size cuff? Should we get a different sized cuff? So I think, and again, with the manual, taking a manual, it's the same thing, troubleshooting our equipment to make sure that we're using appropriate size equipment and so that we're getting the right answer. Anyone else? So I don't want to go into treatment because, like Dr. Wager said, we're going to talk about that more next time. So I know there's plenty to talk about with that. And I don't know if you guys know off the top of your head, does anybody have any recent pediatric sepsis experiences they want to share, or any questions, probably more geared towards recognition, but anything that you guys have seen in your EDs recently? I know this isn't always a large population of what we see, but usually they stick out in your mind.
I would say one of the challenges that we may have, or that I've seen, and that was specifically on a patient we have, is assessing skin color perfusion and that modeling on a non-Caucasian patient. We had that coming in that wasn't picked up quite as quick as what it could have been, and especially when there wasn't a rash with that.
It's very difficult to do, especially in folks who have darker pigmentation in their skin. It sometimes can be quite difficult to pick up that modeling. And there's always then also the differentiation between a newborn who's been unwrapped and gets that sort of, lacy, which can look like modeling, and true modeling. So that's always, for our learners and for us even, sometimes it's a little tough to discern between those, because in sepsis you don't have 30 minutes to put them, wrap them up tightly and put them in a warmer to see if that goes away. You have to act prior to that. So it's well said. It's a difficult thing to look at. There are books and there are, of course, websites that can give you those skin examples, but you're limited then. Nobody's pulling out a textbook at the bedside. And even on your phone then, or your WOW, if you're using WOW, you're still limited then by the resolution and all that. And parent's going to think, what in the world are you doing? What kind of place did I take them to if you're holding the baby's arm up to your phone or something to compare something? It doesn't really instill confidence in them. So agreed, very difficult sometimes to tell, even for folks who do it every single day, 50 times a day.
Any other questions or comments, or we just have a couple minutes? I want to be respectful of everyone's time.
Very helpful. Appreciate that you all have done this for us.
Good. If you guys think of anything in the meantime, I think everybody on here has my contact information. Please don't hesitate to reach out, and I will put you in touch with the right people. If you think of something after the fact, just let me know. And then, as always, I'll try to get it sent out today. The recording, so please, share with all of your staff in the ED. They won't be able to get the CMEs or CEUs if they didn't attend the live discussion, but please share with all of your staff, and let me know if you guys need anything. And like we said, our next session will be focusing more on treatment of sepsis, and really kind of focusing especially on that initial stabilization in the ED setting, and kind of going through that pathway. So hopefully we'll see you guys all next month. Anything else before we sign off?
Thank you.
This is Michelle from Hendricks.
Thank you.
Can you send that triage tool separately out of the PowerPoint?
Yeah, do you have the question? Yeah. Yep, I can do that.
Thanks.
Yeah, I know it's kind of hard to see on there.
And it's available for free on the web. If you just Google Pediatric Septic Shock Collaborative, that's a lot of words, but it did. This is coming from someone who talks about, gumdrops and roses and rainbows all day long in the pediatrics world. And then also the trigger tool, if you type in those words, trigger tool, or if you put PSSC trigger tool, it'll bring that up in a PDF form for you.
And I can
Thank you.
have the link to that website too, so everybody has it. Okay, well, thank you for coming and talking with us today, and thank you everybody for being on, and we'll see you all next month.
Thanks. Have a good day.
You too.
Thank you.
That was great.